actually Botox for urgency and urge incontinence we use very rarely. That's the last resort for us, as many of you were asking yesterday. First is medical therapy, lifestyle modification, other things. So this patient we have chosen for this conference around 2.5 months ago and motivated her, and we were calling her every week if any problem is there. Till last day, patient was very sure that she is going to come. Till last day. If few days ago she would have told that she is not coming, maybe we would have made some other modification. Till last, and she had very good urodynamic findings of detrusor instability. So we thought she will come, but last moment we started on Saturday, Friday morning, she said, I'm not coming. When we started requesting her, literally requesting her, then she switched off her phone. Okay, so then what we are going to do now, we have one patient who is a patient with chronic pelvic pain, and all other things have been ruled out for her. So we'll just look inside the bladder, so you all will get an idea of cystoscopy. And Dr. Amita will just inject few saline injections. We are not putting Botox in her, just 1 or 2 injections just to show it. It is the same technique, okay? So we thought anyway our 20,000 was saved, because Botox is very costly, but it would have been very nice. So till they start from there, I would like to tell you one more thing which we have seen in our practice. Imagine the bladder was overactive, we have relaxed it, okay? Now it might become hypotonic, not able to contract. So I think more important than putting Botox inside the bladder, more important thing is to train her for the bladder drill, or what we call as bladder training. That is very important. If you combine these two procedures, the effect lasts for, usually you need to give repeated injection of Botox, that is one more problem, in 6 months to 1 year's time. But if you do like this, it might last for 4 to 5 years if patient is, because bladder training later starts working very well. Can anybody tell me, are we ready in OT?
The first case, we have the operating surgeon, Dr.
So I have been told, like you were, I think, already telling audience that the original patient is not here. So we are now going to do a cystoscopy in a case patient of chronic pelvic pain. She's suffering for last 10 years, and probably diagnostic laparoscopy has been already done, which was normal. But last 6 months she is having some irritative lower urinary tract symptoms like frequency and urgency. So anything else in the history important? I think
She has been treated several times for PID. She's also undergone an orthopedic evaluation. So for musculoskeletal causes, which was also normal. She has no associated gastrointestinal symptoms as well. And now since the past 6 months, she's been having the urinary complaints. Examination wise is also everything normal. So plan is to go ahead with a diagnostic cystoscopy to rule out interstitial cystitis.
Okay, diagnostic cystoscopy to see the cause of her irritative lower urinary tract symptoms. And for just educational purpose, I can demonstrate how to inject botulinum toxin, because we are, I think, doing cystoscopy for the first time in this patient. So even the Botox injection or botulinum toxin injection is the treatment part of bladder pain syndrome, but it's done at a later stage once oral medications and even the intravesical instillation and other therapies are not working. So that's why she might not be ideal candidate this time, because this time it's the purpose of cystoscopy is mostly diagnostic. So I will just for the educational purpose demonstrate how to instill Botox, and will just give you an idea what are the precaution, everything which is needed. So how many of you are doing cystoscopy regularly? Dr. Diksha, can you ask them? The audience?
1, 2, only 2, 3, 4, 5, 6, 6.5, 7.5.
6.5.
7.5, because he's raising this much hand only. So
I can see that still we are very hesitant in doing cystoscopy, though we are very well versed with hysteroscopy. I think you can ask, hysteroscopy must be done by all the persons sitting
I'll
here.
ask, how many of you are doing hysteroscopy? Hysteroscopy? APGs, please raise your hands. Something you have seen? No. Almost everybody.
So that's the thing. So there is, very minor difference between cystoscopy, hysteroscopy. The major difference is only that you are actually entering into the different organ. So because the organs are different, that's why the way the thing is done is also a little different. The hysteroscopy is done in uterus, where the cervix is quite uh, you know hard in consistency, or you can say firm in consistency, and because of that you need to dilate it. But for the cystoscopy, urethra is quite a soft structure. Normally you don't need to do any dilatation. Usually 17 French scope, which the sheath of 22 French, you can easily introduce in a female patient. um, yeah, always do a kind of local anesthetic insertion, like 2% xylocaine jelly or something before inserting this cystoscope. If you can show the scope right now, where is scope? So just for the demonstration purpose, everything is same, but the difference between the scope is that in hysteroscope, you can see there is nothing, no hood or something at the tip of this scope. So you can see. But in the cystoscope, you will find a hood. So it is to make it a little blunt, so that it shouldn't injure the bladder. Because again, the difference is that uterus, myometrium is quite firm. So injuries are not that usual. But in cystoscope, if you are inserting and you are inserting with force, then probably you can even rupture the bladder. So that's very important. You have to insert the scope under vision, and you have to stop once the bladder neck is reached. Then gradually you have to visualize each and everything. So I can show you the cystoscopy first. Don't think so you require how to assemble, require to understand how to assemble the scope. This all things are same, and actually today I am doing the cystoscopy with a hysteroscope. Second thing is botulinum toxin. Dr. Diksha, have you already told them what are the indication of using botulinum toxin in a patient of overactive bladder?
Indication as in failed medical management. That's what I thought.
Yes,
You want
so
to tell me?
yes, yeah, you're right. Refractory overactive bladder, where you have already used all lifestyle modification and even the medical management in a fairly good manner. In a patient compliance should be good. Enough time has been given. So if everything is not working, probably before going for the botulinum toxin, 2-3 things you have to confirm: the confirmation of diagnosis. So it's preferable, not mandatory, to have a urodynamic study to confirm the thing that yes, the bladder contractions, the detrusor instabilities are there in filling phase, and also the bladder capacity. It should be at least 150 ml. If the bladder capacity is below 150 ml, which is fine in many other diseases, if there would be associated disorders like tuberculosis, which is pretty common in Indian setup, then probably doing a botulinum toxin injection is not going to help. Why? Because you cannot increase the capacity beyond that thing. So then that's why probably these are the patients who are the candidates for augmentation, cystoplasty, or some other thing to increase the capacity of the bladder. So you understand, one prerequisite is a good bladder capacity. So by cystoscopy, whenever you are doing bottom toxin injection, by doing cystoscopy, you are going to check the bladder capacity, that is anesthetic bladder capacity. The functional could be very low even during your urodynamic study or looking at the bladder diary, but the anesthetic bladder capacity, it should be beyond 150 ml, then only you should insert a botulinum toxin. So should we start with the cystoscopy?
So meanwhile, Deepa, can you, as the scope goes
Jelly?
inside, can you introduce us to the team of nurses and the anesthesia
Please,
people?
please,
Yes.
can you tell me? I just want to know the name of our, assistants. You are
Dr.
Nagratna.
Sister Nagarat.
Sister Nagratna ji, and the anesthetist team. May I know the names? Can you show the Dr. Pallavi is with me. I'm having a very enthusiastic team. Everything is ready for me, and I'm getting assisted by Dr. Vival. She's there, and whole of the team of I think first year and second year students are there. So thank you very much for giving me the support. And so it's better to push a jelly beforehand. It will actually in post-operative phase it will decrease any discomfort. So it's better to push the jelly 2 to 3 minutes at least before doing the cystoscopy. So normally we have a jelly with a nozzle at the top, so we can push directly. Otherwise, you can utilize some syringe or something. You can see the vagina. So you just see how I'm retracting the both labia minora to expose urethra. You don't need assistant for that thing. And you can see this is the urethra. Are you able to, yeah, so you are able to locate the urethra. So what you have to do, you have to push the jelly inside. Okay? So looking at this thing, right now, you take the opportunity to see whether there is any band or any kind of fibrosis in the vagina, because this is a patient of chronic pelvic pain. Now I'm starting the cystoscopy. There shouldn't be any pressure. So another difference between cystoscopy and, so there should be, the difference between the thing is that we don't need pressure for doing cystoscopy, because it's very, I told you that it's very soft structure, so you don't need pressure to negotiate the urethra. Now I'm entering. So now, so the 0 degree lens is better for looking for the whole urethra. For the 30 degree, it's little difficult, but yes, you can see the bladder neck as I'm showing here. Are you able to see?
Yes, we are able
Okay,
to
so
see.
you are
It's
entering. The
beautiful.
bladder neck is quite good. There's a good cooptation of the at the bladder neck. You need to open it, and here you can see what is it. It's the right ureter. Are you able to appreciate? You can see the little bit of flux also. I can focus it for a while. Light off कर दीजिए अगर दे दिख रहा तो. Now you can see it's moving a little bit, or sometimes you just need to go.
Yeah,
now you can
beautiful.
see it's moving. Okay.
Beautiful.
Have you appreciated the thing?
Yes.
Okay. So once you have located one ureter, this is the first thing you will encounter. This is the trigone, and you have to appreciate the interureteric ridge. So this is the ridge which will connect to the other side of ureter. So this will be a better way to localize the other side of ureter. Now you can see the left ureter.
Yes.
Will you?
Yes, we can see it.
Yeah, now you can see it's moving again. So it's the
Yes.
flux which we can appreciate. And that's below the interureteric ridge, this is the trigone. And you can see some white plaques just below at the level of bladder neck. It's squamous metaplasia, which is pretty common in chronic irritation cases, and it is not a pathological thing. Now there are many ways for looking into whole of the bladder. So what I do, I start from the one ureter, then I go to the right lateral wall. So in this way you can see the whole wall. And especially for interstitial cystitis patients, you have to look for Hunner's ulcer. So you can appreciate the whole lateral wall I have shown you. Now after that, where you will reach? You will reach to the dome. And how to recognize the dome, which is because of the presence of a, usually there would be a bubble.
Our PGs are saying with the help
And now above the dome is anterior wall of the bladder. So you can press from with your one hand at the suprapubic area, and in this way you can visualize the whole of the anterior bladder wall. So you have to actually come till up to the bladder neck. That's very important, because otherwise you can miss something, and then you will be cursed by urologist that you have not done the cystoscopy in a proper way. So diagnostic cystoscopy is the thing which should be learned by each and every pelvic surgeon. Now you can move to other side of the lateral wall. This cystoscopy is required actually even for, after putting slings. So this part, the junction of the dome and the lateral wall is the most common site where, once you are doing sling surgery, then there could be perforation. So that is the most common site. Now you can see the whole of the left lateral wall. I have reached up to the left ureter. Now, for the interstitial cystitis part only, I am telling you that there is one thing, that hydrodistension, you must have heard about the treatment part. For that, what you need to do, that you have to keep the saline which is filling the bladder at the level of 80 centimeter of height from the pubic symphysis. This is the pressure, this is the water pressure which is required to fill the bladder. You cannot do the hydrodistension at any pressure. So then you can see what is the actual anesthetic capacity of that patient. So I think everybody has now know how to do the cystoscopy. This is the posterior wall, which we have already, above the trigone, and between the dome and the trigone is the posterior wall. So we have visualized all the walls. Now we can proceed for the not the Botox but normal saline I am injecting, just to demonstrate how to do the thing. So what now I can tell you how to prepare botulinum toxin. So the botulinum toxin is actually for the treatment of overactive bladder. Usually we utilize the type A1 of the toxin. There are many types of toxins available, but type A is the most potent and having the most extended duration of action. That's why it is clinically used. And normally for overactive bladder, it was in 2013, it was FDA approved for the treatment of refractory overactive bladder, and usually 100 units of toxin is used. For neurogenic one, you can use up to 300, but for the overactive idiopathic detrusor instability, it's 100 units which should be started with. The contraindication is urinary retention. Patient shouldn't have even PVR more than 200 ml, and active urinary tract infection. These are the contraindication. Relative would be the any neurological problem, then you have to be very vigilant, because you can do this procedure in local anesthesia as well, but if patient is having any kind of neurological problem, it's better to do it under general anesthesia. The aminoglycoside should never be used with this thing, because that could interact and can potentiate the neurological block. So no amikacin or something should be given these patients. And also you have to tell patient there are 4 to 10% chances of developing a urinary retention. So if this would be there, then probably it is a temporary thing, but probably patient need to do a clean intermittent self-catheterization. So these things should be explained beforehand, before putting the botulinum toxin. So you can show this Botox. You can see this is type A Botox, 100 units. So once you will see we are not going to prepare it, but I can show the thing. Aram se. It's a costly thing. In India, market price is around 17,000 to 18,000. So you have to be very careful. You can see, you will find nothing inside the bottle. It seems like it's empty, but actually it's a crystal-like thing. If you will rotate it, you can see some colored things, some colors. Or you ऐसे rotate करें तो ये दिख रहा है ना, इसमें दिखेगा नहीं. But you can see some kind of few colors of the things that is actually shows that yes, this having a toxin inside. So what you need to do, that to reconstruct that thing, you need 0.9% saline. And what I usually do, I reconstruct it with 6 ml of 0.9% saline. And you never need to shake this botulinum toxin, otherwise it get destroyed. So what you need to do, once you have made it, you just need to do a very delicate movements to just dissolve it. You can't shake it. If you will shake it, then probably it will be destroyed. Then after reconstructing it in 6 ml, you can then make it either 20 ml or 30 ml. And then you can inject it at either 20 sites or 30 sites all around the bladder. Usually dome is not touched because at dome there are more chances of intraperitoneal spillage because it's difficult to do. So usually we cover all the posterior wall and lateral walls, try to do the anterior wall. The previous thought that trigone will cause a vesico-ureteric reflux, nowadays it's not so. We can inject trigone specifically if we are doing for some kind of, voiding dysfunction or interstitial cystitis patient, because the trigone is the most sensitive part, so you have to cover that. Can you show the needle? So this is the needle. It is around 35 millimeter long, and its beveled edge is there. So we can, so we will introduce it with, usually we keep the needle inside because we don't want any spillage inside the instrument. So basically, just to tell you that usually it's you have to penetrate around 1 to 2 millimeter inside. If you are you suppose that you have penetrated deep, then probably you can spill the toxin inside the peritoneum. So it's better. You have to do a intradiffuser injection, so it's better to withdraw a little bit if you are confused. And there shouldn't be any bleb nowadays. It is said the bleb, if bleb is created, it is actually sub urothelial injection, and it might not be completely into the detrusor. So it's better to create a wheal rather than a bleb. I will just show you if I would be able to see inside the camera. Now we are inside the bladder, and just for demonstration purpose,
Naga
I am
sister,
now putting
light,
needle.
Nodi, light
There is a
connected
jelly. Now you can see the needle. So you can see, now you can see the, the edge of the needle. So you need to see where is the ureter. It's, so I can see this is the interureteric ridge. So I am just doing above the trigone. Okay, so this is the part where I am pushing. Now just a minute, हाँ अभी करो. फ्लूइड ऑन है, हाँ थोड़ा सा डालो. 1 ml के अराउंड डाला जाता. So you have to push around 1 ml inside. Okay, and then you at the distance of 1 centimeter. So what you can do, you can make a kind of map that yes, put. So actually you don't, there should be only a wheel, there shouldn't be any bleb for this thing. And you can you can go from the below upwards till the dome, and then at 1 centimeter apart you can go laterally on both the sides. So this is the way. Yes. So you can see that I am not actually causing any kind of bleb. Be vigilant, never inject it directly into the blood vessel. So any questions, anything is required?
Dr. Amita, they are asking that once you have injected, when do you want to repeat the injection? What is
Achha, that's a very good question, because the effect usually comes, the clinical signs will usually appear in 2-3 days, but the maximum effect may take time of 5 to 6 weeks to come. So you can continue your anticholinergic or whatever medical treatment till that time, once the patient is having the maximum effect. Usually what happens that after 3 months or 12 weeks duration, there would be new axon formations, sprouts would be there, and they will rejoin the end plate. So there will be some comeback effects, but actually it takes around 6 months to completely the primary neuron will have the complete recovery after 6 months. So usually we don't repeat these injections before 6 months. There is other reason also not to repeat it too frequently, because otherwise there would be antibody formations. So patient will develop resistance. So there shouldn't be short duration of repetition. The effect might last up to 1 year, so you can have a gap of even 1 year. There is no upper limit of the interval gap, but yes, a lower limit is 6 months. And never use higher concentration as well if it is not required, because it can cause antibody formation and resistance. Anything else?
Excuse me, ma'am. Side effect if the injection goes into the peritoneal cavity by chance.
So the thing is that in peritoneal cavity, there won't be much side effect, but yes, you will lose that injection. That is the thing. So that's why it's advisable that it shouldn't be through and through.
Thank you very much, Dr. Amita. This is Dr. Priya Balal here.
Yeah, thank you
It
so
was a
much.
lovely session. I thank the team in the OT. It
समझ
was
में आ
very
गया?
clear, and
उतार दो, ये
I
तो
think
उतार
all
दो,
the postgraduates would
ये उतार दो पहले
benefit
माइक.
from the stepwise demonstration of cystoscopy. Thank you.
Thank you so much.
To please give our token of appreciation to Dr. Amita ma'am for the lovely session.